Hey, everybody. This is Erica Mello, and in today's podcast, it's actually really an interesting patient. We've had a lot of patients that we've spoken about who've had hips and low back issues, and this particular patient has a shoulder issue, and it's a great story of an ex-professional football player who had a right shoulder injury, and the cause of his problem was an old surgery that he had on his opposite shoulder. And it's quite a very specific way that we use the whole clinical reasoning process to determine this. So enjoy, and thanks again for all the ratings and the comments. We really appreciate it.
Hey everybody, it's Erica Mello and Susan Clinton, and we are Tough to Treat. And we want to thank you so much for listening to the podcast, and we've really enjoyed doing it, and it's been a lot of fun. So today I thought we would do a shoulder patient, since we haven't done one. Actually, I don't think we've done one ever, right?
I don't think we have.
Right. So it's good. I think it's good to do sort of a little bit out of what we normally see. And I do see a fair amount of shoulders, but I tend to see more, low back, hip, that type of thing as well. But this patient actually was very, very interesting. And it's funny because I actually saw two people at the same time, and both men, and they had similar symptoms, basically, but very different treatments. So I'm going to talk about one of them because I wanted just to bring up a point as well about professional athletes. So this guy was probably it was about 3 years ago, so probably in his late 30s, maybe early 40s. He's a former professional football player with the NFL, and he was referred to me by his personal trainer. And he had a long history, as you can imagine. He played with one of our local teams here for many years, and he had an issue with his right shoulder. He could not, so he was really had doing some heavy training, still wanted to keep in shape. So he couldn't do a push-up or a bench press without right shoulder pain. And his history was, besides all the extensive issues being a professional football player, he tore, if you can imagine this, his sciatic sheath while leg pressing some 500, 600 pounds. It was, I don't have his chart in front of me, but it was some absurd amount of weight, Susan, where he literally had to stop football. I mean, it was so bad. Can you imagine?
Wow.
The nerve pain. He had to fly to California, I think, to quote him, he was in a very dark moment in his life. So he went into severe bouts of depression for over a year, and he had finally come out of it. But just thinking about that sciatic, just, it's one of those, those are the dims, right? The danger in me. When you think about something like that, you're like, holy smokes.
Right. Exactly.
So that's his history. He had a ton of other injuries, but the one that was relevant to this particular issue was he had a labral repair on his left shoulder. Don't remember exactly when at the time, but it was part of the history, but more recent than his other injuries. And I'm sure he had it rehabbed. And when I was asking him, I said, did you get, physical therapy and things like that? He's like, yeah, I work with the athletic trainers and things. And I love athletic trainers. I think they're great. But I don't think the team actually employed a physical therapist on site at the time. So, and I think a lot of professional athletic teams don't have that PT with the team. I don't know about you if you know any of your Pittsburgh teams, but I know the New York Knicks have a PT, who works with the team pretty much every day. I don't know about any other teams, but I don't believe that he had one that was dedicated. I think he went outside the facility, which is fine. But I sometimes wonder why these guys are professional athletes. They don't get PT right on site on their training facility 5 days a week. And I was lucky enough to consult on a professional baseball player a couple of years ago. Same thing. No PT on site. And anyway, that's another issue, but I just wanted to bring that up because I think it was relevant to his issues. So he had the labral repair, and what he couldn't do is that, so basically, I'm going to backtrack. When the personal trainer referred him to me, she said, there's one thing I noticed when he does a push-up, or mostly a bench press because it's easier to see. When he does the bench press, his right arm is way higher than his left. So he's lying on his back and he's hook lying, or he's got his feet on the floor. He's doing the bench press. So he's almost like in this left rotation of his, so the barbell is almost, it's not straight. And I said, oh, okay, that's very interesting. So
that's interesting.
Yes, it is. So it was hard for me to actually see him do a push-up in the evaluation because it's so much, he's a big guy, right? So I said, let's mimic the push-up motion without weight. So as I was listening to his story, I just kept thinking of all of all of the issues he's been through, and I'm sure many medications and not to mention other things that they give them in professional athletics these days. So, but he had told me that he had been seeing an orthopedist here in New York City, been giving him repeated cortisone injections to his right side. So, which he was like, that's nothing new to him. So, but he was given the diagnosis of an AC joint arthritis on his right side, which is his symptomatic side. So he'd go in, he'd get the cortisone shot, he'd feel a bit better, and then he'd go and do his push-ups, and then he wouldn't feel better. So, and his bench press. So what I ended up doing was I said, okay, let me just watch you just sit for me. I listened to his story, and I think with something like that, especially with the sciatic sheath, I needed to get his sort of emotional state about injuries, because you go from, being a really stalwart professional football player to going to a deep depression after tearing your sciatic sheath. And
after having to change your whole world from if that was one of the precipitators for him leaving the sport.
It actually was. And so I said, let me just have you sit and just put your arms out in front of you and just reach for the opposite wall. I just want to see before I get you on your back. And I wasn't about to sit there and look at his standing posture. I mean, this is not really helpful at this point. So I had him sit, and I just said, bring your arms out in front of you and just reach. And that right arm was going, and that left arm wasn't going. And I'm like, why is that happening? And I just said to myself, could it be the left shoulder problem? Could it be the labral repair? So I ended up saying, well, maybe I'll check the range of motion there. I'll check to see, because he could have some scar tissue. The most recent injury was his sciatic injury. So the labral repair on the left shoulder was prior. So I said, well, I've seen, issues like this before where old injuries crop up, as we talked about in other podcasts. So I had him lie on his...
But his symptoms were on the right side, right?
Correct.
Okay,
correct.
I'm just making sure I got that, because I missed the left side was the shoulder.
Yes, that's what's
repair.
So
okay, so the right side is the painful one, but that's the one he's moving the most.
Correct. Exactly. He's getting the repeated cortisone injection. He's given a diagnosis of AC joint arthritis, pushing through the bench press, and then God knows what he was doing in the push-up, because he probably was like, I didn't really want to look at that the first visit, because that's kind of tough. But so then I said, all right, lie on your back, because I just had to see how he did a bench press. No weight in his hand. I said, just do the same thing you just did in sitting. So he pushed through the hand, same thing, right shoulder, right arm going, left arm not moving. So I went in and I said, I need to look at this left shoulder, his thorax, his ribs, whatever. And so I'm assuming you got decent care, which was a false assumption on my part at that point, I think, because he didn't get fully rehab from that left shoulder is what it came out to be. So, I mean, he had full flexion, he had full, he's hypermobile. So he had the external rotation he had was stiff for him, but you expect that after a labral repair. However, he's hypermobile. So he's doing full push-up. He needs more than the external rotation that he has. So internal rotation was normal. So not a ton of crazy restrictions in his left shoulder. So then I went up into his armpits. I always tell therapists, I don't know if you've had this experience when I go. So I got him back up and sitting, actually, and I went into his armpits. And I've had the experience in the past, because it's so innervated up there, where I've had a patient literally pass out when I've gone up into the armpit. And I'm just digressing for a second, because if you go up in there, and I'm very sensitive up there, but I had a patient literally pass out in front of me, and I caught her and I tore my hamstring in the process. So I will never forget that experience as long as
oh my goodness,
anybody's going up. I mean, I don't know if you have that experience, but
it makes sense. But, people do get a little funny in that area, but you're thinking about, you're full into the brachial plexus, And you're also bumping right up into T1, and that whole, and that visceral crosstalk. And that's all occurring up in that, cervicothoracic region where, you got your stellate ganglion and, the beginning of the sympathetic chain gang and where parasympathetics meet up. And it's a busy area, and it's one of you can access that area, neurologically pretty easy that way. So, yeah, I mean, I can imagine if somebody is like super sensitive or a bit imbalanced autonomically that you kind of climb up in there, you can kind of tip the scales a little bit.
Yeah. And
sure.
And I haven't, that's, I've experienced that once or twice. I mean, the only time was this person almost passed out. I think I was worse off than she was when I tore my hamstring. But my point is, so he was pretty robust, a former professional athlete, but nonetheless, I had him seated. I got up in the armpits and I just assessed to, make sure he wasn't getting sweaty or anything. He was fine. So I really went up into that, second, third rib up there. And it was so, and I know this is sort of a bit of my biomechanical bent, and I tend to go that way. And I get that. So, but with him, I just didn't understand why the right shoulder was so far forward and why he was complaining of pain on that side. Because those were the only two things he couldn't do. He could do full, military press, any other thing the trainer put him through. He's fine. Planks, fine. It's when he actually had
to
yes.
Wow. Okay.
Yes.
Yeah.
Exactly. So it's when he had to move a weight in that sort of fully loaded bench press push-up position, and he was hypermobile. So anyway, so I got him up in there. He was literally almost jumped off the table. He was so sore up there, and nothing really on the right. And I was like, well, you've got a bunch of stuff in you. You've got your intercostal muscles. You've got your brachial plexus. So I said, I'm just going to have you do a couple things in sitting again. Move your hand in front. Just do the same thing. Reach for the wall. He did, and the right arm shifted. And his entire left side, I can't explain it. It was almost like it contracted. Does that make sense?
Yeah.
So
like he pulled back, huh?
So he basically reached for the wall. The right arm went forward. The left arm was almost like retracting, if you can, I'm just using my hands, almost like taking it into like a retracted posture, and that intercostal parts of the serratus, they were just gripping, and I'm like, why are you doing that? He's like, I don't know. So, and I often think that people just tend to focus on the symptomatic side. And it was his opposite side at the end of the day that was the cause of his problem. This is where I'm going with this. But it's something that for me, because I just love to figure this stuff out, it was just these two maneuvers. That was it. Bench press, push up. Everything else was good, as I mentioned. So I said, why is he constricting? Is it the labral repair? He has pretty decent range of motion, not crazy. I mean, nothing really that would indicate that why would he do this? And I don't know, I'm just going to stop for a second, and I want to hear your thoughts on it, and then I could tell you what I possibly
no, first of all, I find this very interesting, that it's the movement under compression piece that got him. He can actually, if he can do a plank, he can get set and get there and do it. But it's the bench press or the push-up, which is, you're looking at, two different kinds of movements that are actually the same movement under two different kinds of conditions. Yep. So I find that extremely interesting, because that one actually kind of confirms what I would have done immediately if I had seen that was, obviously do the same movement under a different condition and see if it reproduced. If it did, it's like, oh, okay, we've got to just, get the brain to think differently.
Yes.
But this was like pretty, confirmational that this is the movement that's really, giving him a lot of difficulty. Did he have trouble pushing doors open, like really heavy doors, or did he even say?
No.
So it took a lot of load then for it to really come on.
Yeah, I think it was a bilateral load, not like he could do like military press one side, not bothering him. So it was when he had to activate that left side.
Yeah, so the two together, which is really interesting. And the asymmetry of movement, and all, again, asymmetries are the rule. We all have one side that doesn't move as well as the other, or it moves different, or, this or that, or I don't really freak out about those. But when it's something really obvious under a certain condition, it was kind of like, okay, why motorically is he choosing to move that way? And I think some people would probably say, well, let's just get him to back off on the right side a little bit and stabilize that scapula and pull this way. But to me, it just seems like it was obviously being pulled, like his whole right side was being pulled that way. And I'm not even seeing him, but I would want to, my confirmational bias first would be, I would have to just tell everybody, I love to challenge him. My first one would be like, okay, why is he not stabilizing on that right side? Well, how, come on, Susan, let's think a little bit deeper. And then it's kind of like, well, why is he overcooking the left side? Yeah. Because that's kind of like, wow, if maybe the right side is fine, but it's the left side that's just, for whatever reason, he's just really overweight, especially when you went in and found soft tissue stuff and hypersensitivity of the nervous system in there and things like that. And of course, if he's got a hypersensitive nervous system on that side, he's going to protect it.
Yeah.
But I loved how you asked him, what are you doing that for? Because you never know what people are going to say, because sometimes when you bring it to their awareness, they're like, I had no idea I was working that hard over here.
Right.
So I think that's fabulous.
Yeah. Well, it's funny because the trainer noticed it, and I'm like, a lot of trainers just sort of go about it. They don't really notice stuff like that. And this particular trainer did. And I was like, oh, thanks for the heads up, because I wasn't about to get him on 100 pounds on a bench press the first visit. So I ended up, what was very interesting, I was treating another patient at the same time, same referral source, actually. Same thing. Guy couldn't do a bench press or a push-up. And I said, oh, God, I have to separate the two because I'm going to just go the same route. But I'm not going to talk about this patient. But ironically, his issue was also on his left side. He had an old clavicle fracture on his left side. So, but that's another podcast. So I was treating them at the same time, which I think may have been good in a way. But anyway, I'll proceed on. So what I ended up doing is I had him started having him breathe. The guy's gripping into the armpit. I just to do a couple like lateral breaths. We sort of figured out what breath better worked for him in terms of releasing those muscles in his left armpit. So I said, just do an upper chest breath, do a diaphragmatic breath, do a lateral costal breath. And the upper chest breath really felt like the whole left side was releasing. And I was able to get in there a bit easier. Okay. And he kept doing that and doing that. And so I said, I'm using my hands here. Let me just sort of try to stack you up a little bit. I hate to use that term, but it's almost like I just wanted just to center him, basically, just get him centered. And the minute I just started having him do some breathing, I was moving a little bit, his sensitivity dropped dramatically, and I was really in there with my fingers, really in the ribs and really in the intercostals. So all of a sudden I just felt everything sort of let go and everything. And so he didn't have that gripping sensation in the left upper ribs, in the armpit. He didn't have any of that. I said, okay. So I'm literally there with my hands holding him in that position. I said,
Erica, just real quick, just for the listeners to understand, are you in front of him or are you behind him?
Oh, I'm sorry. I'm behind him.
Okay. Yeah, that just helps picture-wise.
Sitting on the plinth, and I am behind him.
Okay.
So I've got my hands both in the armpits. The left one, my intention is on that left side. I've got my fingers probably on 2, 3, 4, and I'm just having him do some lateral costal breathing, and I feel the relaxation. I'm trying to sort of, this is the work I've done up with LJ and Diane, just trying to just sort of relax and just slot those ribs in, and I did. But it was a lot. The breath helps so much, as you know,
it's everything, right?
Totally.
Everything.
So, especially when you're up in their armpits, right? So I had him just do a few more breaths, and I said, just take your arms and reach for the opposite wall like you did at the beginning. And he did, and and the right arm was just as even as the left. So
the left arm moved again.
Or the left arm, exactly. So the right arm stayed put. So I said, oh my God. So I had him do it a few times, and I felt a little bit of the gripping in the back of the scapula, but I didn't go there because I'm focusing on the upper ribs here. So I just had him say, move your arms back and forth. Just pretend you're just pushing a weight. Then I had him go back into supine. I had him just put his arms up, in 90 degrees deflection as he was going to simulate doing a bench press. I said, no. So I had to readjust my hands. I was sitting behind him at that point on my chair, on my stool. He was supine, knees bent, arms up in the air. I got my hands under the ribs again on his side, had him do a few breaths again. And I said, just pretend you've got a 100-pound weight in your hand and just do a bench press for me. And he did, and the left arm was fine. It was almost perfectly symmetrical. And once again, when you're loading heavy weight like that, he can't have a lot of asymmetry up at the top of the press, because, as my opinion is that, I think it was precipitating and making the injury worse. So I actually got some weights. I took 225 pounds. I put him in his hand. I said, this is a lot of weight, but not for him. So I basically did the same thing. I had him do some upper chest breath. I got in there, released some of the intercostals. I said, just pretend you're doing a bench press. And he did it, and it was fine. He had no pain at all, But this is very low weight for him. So
but that was good, because you were able to scale it and begin to get a change so that his motor system could latch onto, and his nervous system wasn't going to overprotect. So sometimes you have to climb under the guard. I realize that, yes, he wants to, do 100 pounds, but if you can get some motor control changes, and scale back, realizing that you'll go back to that 100 pounds, and hopefully that 100 pounds will feel good when you get there, it's worth it, I think, to kind of scale back and work on that, because it's too hard to do under that heavier load that he's like, super overprotective with.
Yeah, and I said to him, after I asked him about his rehab for his shoulder knee, I said, did you, what kind of rehab did you have? And he said, normal. I probably didn't remember at that time, but it was fairly, straightforward, post-op rehab. But he did tell me that he always had some issues afterwards with moving that left side. And I didn't know him at the time. I don't know what the deal was. So, but he didn't think anything of it, because then he tore his sciatic sheath and his world changed. So that was not a big priority for him. So I ended up taking the 25-pound weights out of his hand, and I said, just show me 5 pounds. And we're not going to breathe. We're not going to do anything. Let me just watch you with 5-pound weights. Put the 5-pound weights in his hand, and then boom, his old strategy came back at 5 pounds. And I said to myself, this is going to be the kind of a rehab or of a treatment that I'm really going to have to take him at it way down, very low in terms of weight, which is, going to be for him almost humbling or embarrassing, right? So I do tape a lot. So what I did was I ended up taping his upper ribs. So basically what I do is I tape from behind, on that left side. So I took a piece of Hypafix Leukotape. I had my hands in his left axilla, and I was pulling the tape down to see where I could feel where it was less gripping. But I just wanted that gripping and that tone to decrease. So I basically took the tape and I ended up pulling it down till he finally relaxed. I know it's I probably didn't describe it that well, but it's almost like an intuitive sense for me. So
were you taping over the upper trap and pulling straight down over the scapula? Or?
No, I wasn't over the scapula. So I was basically on close to midline, maybe an inch and a half away from midline. And I just had my hands in the armpit, was pulling. So I corrected with both the Hypafix and Leukotape. So it was almost on a diagonal from left to right, not crossing midline. Okay. And I did the same thing with the Hypafix, diagonal left to right, not crossing midline, did not cross the scapula.
Okay.
So then I just said, lie down, put 5-pound weights in your hands, do some breath work. So I had him do the breath work every time he bench pressed. So breathing out into the axilla. And what he did was he was able to control with the 5 pounds with the tape on. And I said, okay, let's try 25 pounds just for the heck of it, because the weights were still in the room. And he was able to do it for maybe 3 reps. And that was it. And then he failed at that. So I'm going to stop again, and I'm going to hear your thoughts.
Yeah. Well, no, I appreciate it. When we talk about taping, I know there's a lot of stuff out there about taping, and people kind of start running up and down the street screaming, no evidence. But I think, when we think about taping, it's a novel input to the situation. Right. And, it's a sensory input. And what you were doing, where you were trying to just, can I give him something that he can use temporarily, to give him that sensory input that'll help him begin to change his motor behavior. And, and then I love the way that you went back to like the smaller weights and let him get a feel for that, because, when we're kind of playing around with the motor control system, we have to wait for the brain to catch up. You've got to always, I know I've said this before on the podcast, and people who have heard me in my courses, hear me say this. But I think that, we build these motor patterns, we really get good at them, and even if they're not the best patterns in the world for what we're trying to achieve, for better or for worse, our central nervous system adopts them. And following surgery, following problems, maybe following all of the things that happened since his left shoulder surgery, he just got into the pattern of just overprotecting that left side.
Yeah.
And man, when you start doing that, you have to, so I feel like basal ganglia goes and sits down in a chair and says, I'm done.
Mm-hmm. Yeah.
And so I call it kicking basal ganglia out of the chair.
Mm-hmm.
We need a new motor map.
Yep.
We need some choices for the brain to be able to make.
Mm-hmm.
And sometimes we want to give it to the patient as much as possible so that intrinsically they're making the change, but sometimes they just need some help to be able to get it, and especially if they've been doing it for a really long time. So, I love the idea of doing a little bit of tape. I love the idea of your hands. I love the idea of breathing, because changing your breath changes everything.
Yep.
And I love the fact that it was really the upper kind of chest, and people are going, oh, no chest breathing. And it's like, you didn't mention that you were having them breathe with scalenes and panting. You were just pulling some pump handle motion in.
Exactly.
That's what that is. And so however way you want to get it and they can start getting it, that's something that he's going to be able to take with him intrinsically and use.
Yep.
Because a tape is effective, as we all know, sensory input is, kind of helps. It goes to the cerebellum. The cerebellum can send that upstairs and say, hey, there's a change, sensory change. What do we do with this? It'll say, we'll move around it. Okay. Yep. So they, so we kind of have to, move around it a little bit. But I think in the beginning, when you have somebody who really needs to begin to kind of change a motor control pattern, that sometimes you got to really go down lower a little bit. And I love the fact that you went lower, got him to where he felt like, okay, I got this. Then you loaded him up and you let him do a few reps until, like you said, he didn't have a success anymore. And the coolest thing about that is now he's learned something else, which is you get to do this until you get sloppy. And it's not a matter of, okay, now go home and do this 30 times, that kind of thing, because you don't know they're going to do it and drift back into maybe the pattern that they had before. Yeah. And what you were really teaching him was how to do this, in a different way. A new way, a novel way than he's ever kind of worked before. The other kind of cool thing for everybody to think about is you chose to do the bench press for many reasons, but one of the things that I think is the coolest about it is because he's laying on his back. So there's that input from the table, the floor, the mat, into the back. And I like that because oftentimes they're doing the bench press, they're on a bench, right?
Right.
And they don't get that whole input into their system. And I'm wondering how much that may have contributed into to help him change his pattern too.
That's a great point.
Sometimes off the bench onto the mat, can be a cool thing as well.
Yeah, I mean, this guy's big, too, so, he's on one of those narrow benches, right?
Yeah, and it's like being on a foam roller.
I know, exactly. And it's funny because as I mentioned, I do tape a lot, and I do think people say no evidence, but I've had success with that, and I do think it is novel input, and I do think that clinical expertise does play a factor in a lot of these patients.
Absolutely.
And it's very important to know when to do the right thing at the right time, and I think some of the research out there doesn't take that into account. So I'm a big believer in looking at all the research, but I do believe clinical expertise sometimes trumps that, especially if you see clinical patterns, and everybody's so different. I mean, this guy had an emotional history. That was certainly a factor. Maybe he was gripping his left side to protect himself. I don't know. I mean, who knows?
Right.
Who knows?
Mm-hmm.
But all I know is that when I put the tape on and, as you said, that novel input into the brain, am I really fixing those ribs? No.
I think that's the thing with evidence and taping. It's like when I tape and people want to talk to me about it, it's like I'm actually just trying to influence the sensory system.
Exactly.
I know it's not going to hold a patella in place. I know it's not going to hold a scapula down. I know it's not going to do this.
Right.
But if it gives the person the opportunity to move with less symptoms, I realize it's an intrinsic thing. And I know a lot of people are like, oh, it needs to always come from inside. And I truly, I don't want to hijack their own ability to change their process. But if I can give them a little bit of support while they go home and change their process, realizing that I'm going to pull them back away from this. I don't want them to have it forever. Mm-hmm. And usually I don't know what your experience is. Usually I can tape once or twice and they kind of move on down the road, and I don't need to, add that piece anymore once they begin to learn,
Yep.
A new way of moving.
Yeah, it depends. I tend to probably tape a little bit longer than that, and then I'll stop. But then if they go to higher load and they're failing, I may throw a piece of tape on just for the proprioceptive feedback.
Mm-hmm.
With him, I don't recall taping a long time, to be honest,
mm-hmm.
because I was explaining to him, he's like, well, why is this, giving me, the right shoulder pain? I was explaining to him that because you're hypermobile, you're reaching way beyond your normal range of motion on that right side. Okay, you have a hypermobile shoulder bilaterally, hypermobile joints. Do you have arthritis in your AC joint? I don't know. I don't really care. All I know is that the reason why the shoulder hurts is because you have a poor movement pattern,
mm-hmm.
and that we need to fix that. It doesn't happen in every single thing that you do. So you're going to get, if you're getting, obviously the cortisone injections help short term. There may have been some inflammatory process there when you're pushing, 200 pounds on a bench press, and you're just really trying to push that weight up because it's lopsided. The barbell is lopsided, maybe. And so he actually understood that, and he was like, well, that makes sense, because that's why I'm not getting long-term relief from the cortisone shots. I said, that's because they're treating your symptom and they're not looking at the underlying cause or the movement pattern that bothers you. Mm-hmm. I said, my guess is if I took a look at your push-up, I'd see the same thing, but I'm not going to do that right now because I want to focus on the bench press. And he was fine with that. So what I ended up doing, in addition, I did a little soft tissue work in the arms, the armpit with the serratus, and did a lot of sort of movement repatterning with that. I had him lie on his side, reaching, a lot of PNF things I did as well. But ultimately what I ended up doing, in addition to the taping, was I had him lie on his back and just he's looked at me like I was nuts. I had put 5-pound weights in his hand. I had him do tricep extensions, just basic tricep, to see if he could do that. And he's like, oh, and he starts, and this was probably the third visit, and he started shaking in his left arm. And he had the tape on, and he's doing the breathing and everything. And I'm like, see, you guys are so reliant on your big muscles to do the work that when you actually go into an unloaded situation with low weight and are forced not to use your compensatory moves, you actually can't control the movement. Mm-hmm. And athletes are the biggest compensators of all, especially the hypermobile ones. They take the path of least resistance until they run out of options.
Right.
Ran out of options. So treatment-wise, that's really what I ended up doing with him. I did some taping. I did a lot of breath work in the upper rib cage. I did some work on the left side. I did not touch his right shoulder manually. So I did a little bit of PNF on the scapula, just to scap PNF, some PNF with the upper limbs. I'm not going to get into the details. I just need to train control. And then I started getting him with heavier weights, and then I looked at the push-up. We started with push-up up against the wall. And then I actually wanted to look at his plank. So I got him in a full plank, not on the elbows, just full elbows extended plank. So I had said, full plank, elbows extended, left arm on the floor, and doing like a right rotation.
Come out of the plank and lift the right arm up and back.
Exactly.
Into trunk rotation.
Correct. And then I had him do it on both sides. When he stabilized with the left, he could do a 360. When he stabilized with the right and moved the left arm, very restricted, which confirmed what I thought. Okay. Mm-hmm. So I ended up having him do that against the wall, a full plank against the wall, with the breathing in the armpit, the tape on, having him do some left rotation with the right arm stabilizing against the wall. Mm-hmm. And so I started progressing him along in that vein. I eventually upped the weights. Then I ended up doing, which was interesting, some basically reverse flies. He didn't really do reverse flies in his regime with the trainer, but I just wanted to see if he could control the movement, especially on that left side.
Yeah, that's good, because that's eccentric loading, right?
Right. And so he was okay with that.
Missing. Mm-hmm.
Correct. But once again, I got him at 5 pounds. He was okay with that one. But as we started to increase the load, he had a hard time controlling that left side. So I feel like I did a lot with him, but it was a progression. It was mostly unloaded tricep extensions, unloaded sort of benching, unloaded reverse flies with tape and breathing. And then I had him do some to address the push-up, which ultimately goes getting better, honestly, as we were treating the other movement pattern. I had him do some planks against the wall, elbows extended and into left rotation. And we progressed him, and he eventually got better. And he was didn't get any more cortisone shots. He was very appreciative because he had been through such a poor outcome after tearing his sciatic sheath. He was very depressed about the rehab process and everything. And he was so into figuring out his movement patterns. I guess when you're in the NFL and you're just so focused on what you need to do, then you come out of it and you start to train. And he was highly intelligent. And so I think he really focused on doing that in all other aspects of his workout, not just bench pressing and push-up. He wanted to be able to do a pull-up, which is a completely different movement pattern, but he tried it with the trainer because he hadn't been able to do that. Because I said, you never mentioned you couldn't do a pull-up. He's like, well, I haven't been doing it. The big thing was, I'm like, how dare you?
Well, it's like, oh, this is getting better now. Help me with my pull-ups, so that's good. That's exciting, actually. No, I think that's great because I think what you ended up doing by helping him begin to help himself and change and understand that you deconfirmed the fact that because you have an injury doesn't mean that you're not always going to get better.
Correct.
Right? And I think that maybe what I'm hearing, that you kind of, the conversations you had with him, he had this confirmational bias that I didn't get better after my sheath injury. Why is this going to be any different?
Right.
And I think what's exciting is that he learned that everything doesn't have to be in the same package. Right. He really could change his movement pattern and really make some dramatic changes and have some positive experiences around changing because his previous ones were not that positive.
Right.
Yeah.
Right.
And so that you gave him successes and, he got into it. It worked for him. You strummed his central nervous system in the right way, which was great.
Yeah, and with him, I think that since he was so hypermobile, for me, it's the strategy. You need to change the strategy, change the control. And I often find that, I don't know if you've seen this, people who are hypermobile do better with a little bit of resistance in their system because if they don't have that, they're kind of all over the place and they don't know what to do with themselves. I don't know if that's your experience, but that's what I'm finding.
Yeah, I think, loading helps a little bit,
sure.
But you got to be graded and,
yes,
successful for them.
Yes.
You want them to feel success and feel that they're making progress, but yet you also want to give the brain a chance to catch up.
Yeah.
And to be able to establish and find those new patterns so it has that richness, variability of movement, that varied practice versus just that one way of doing it.
Yep. Yep.
This was exciting.
Yeah, I enjoyed treating him.
it.
Yeah, it's a couple years ago now, but it was fun. He's doing well now, and I don't really see him. So
that's great.
Cool. Very nice.
Thanks for sharing the story.
Pleasure.
All right, everybody. This is Susan Clinton and
Erica Mello.
And we are Tough to Treat. Thank you for listening. Give us a review on iTunes. Thank you for all your Facebook and email and Twitter appreciation notes and things that you're learning.
Yeah.
If you're going to do that, please go to iTunes and give us a review so that others can find us as well.
Yeah, we really appreciate it. Thanks, guys.
Have a great day. Bye.
Bye.